RHW newborn care seminars. So notices about our talks are available on our social media groups. Currently, it's just WhatsApp and Telegram. You can email Julie or myself, and we can send you information about our talks. And a few housekeeping rules. Please ensure you're muted at all times, except, of course, to ask a question or comment. You will have 10 to 15 minutes at the end of the talk for Q&A. Please use the reaction button to raise your hand or use the chat box by writing your name so we know you wish to ask a question, or type a question in the chat box and we'll try to get to as many as possible. And talks will be available, of course, with our speaker's permission on the UNSW website. Over to you, Julie.
Okay, thank you, Rahul. So welcome everyone. This is our last talk for the year. And, it's my great honor and pleasure to introduce Sanjay Patole. I don't think there's any neonatologist in this universe that doesn't know Sanjay. And I had the extreme privilege of being one of his residents many years ago. He was my first fellow when I started in the Royal in Paddington, and I cannot count the number of times he saved me. And I think every time he looked at the roster and saw Julie Uy on it, he did a little nervous breakdown. But you are still here, Sanjay, so thank you. From everyone. So, Sanjay is a master of everything, including Bollywood movies, but one of his fortes is nutrition. And this very confusing and perplexing, probably a new thing in neonatology is a matter of what biotic to use and whether it makes any difference in the long term for our babies in the ICU. So hopefully he can clarify this mystery. This talk will be recorded. Sanjay has given permission, and we'll leave some minutes at the end for him to answer all your questions. So without further ado, Sanjay, it's almost 5 past. Over to you.
Thank you, Julia. Thank you so much for the kind words. So shall I just press the share screen button now, correct?
Yes.
Yes, yeah.
Over to you.
Can you see the slides now?
Yes, looks good. Thank you.
Thank you. Good afternoon, good evening, good morning, based on the time difference, because I'm on Mars for the last 2 years. The topic that Julie has given was quite interesting for me because there is no mention of probiotics, and I'm thankful to her for that. So today in 40 minutes, we'll try to cover different biotics. We'll start with prebiotics, then we'll cover postbiotics. Somewhere on the way, we'll try to cover ghost biotics. And when you are fed up with everything, we'll even cover no biotics. So we'll start now. Let's see. So whenever you want to discuss about prebiotics, it's inevitable that we'll have to cover human milk oligosaccharides, HMOs as we call them, because they are the nature's prebiotics, which are basically very complex carbohydrates, or put it simply, sugars, that comprise the at least 5 to 20 grams per liter of human milk, the third most abundant solid component of breast milk as such. Basically, the structure has a single glucose molecule, which is at the reducing end attached to a galactose, and that forms the lactose core of HMOs. And till date, when I was making these slides, I found out that it's not only just over 200, the current tally is 247 human milk oligosaccharides have been identified. And in terms of size, they go anywhere from 3 up to 32 sugars, and very complex nature as such. 3 major types of HMOs. One is a fucosylated neutral type. Basically, what fucosylation involves is adding a fucose molecule to the basic structure, and that leads to significant changes in the functional properties of the human milk oligosaccharide. If it is not fucosylated, we simply call it non-fucosylated neutral types of HMO. And the third one is acidic HMO, which is sialylated as they call it, which is abbreviated as SL. So wherever you find the SL bit in the HMO description, you know it's the acidic human milk oligosaccharide. 80% of the breast milk will be composing of neutral HMOs. The two magic letters that you would read in the literature will be 2FL, which is basically 2-fucosyl lactose, and the other one is LNT or LNTT, which is lactose N neotetraose or lacto N tetraose. So this is what a important molecule currently in terms of research and the future of prebiotics in neonatology. Remember that either 2FL or LNTT as they call it. Important to know from our clinical practice point of view that the amount and the diversity of HMOs basically depends on the stage of the lactation, changes from mom to mom, changes from pregnancy to pregnancy, changes every week of lactation, and it depends on ethnicity and place of origin as well, because that's the evolutionary basis of whether the mothers will secrete enough amount and diversity of HMO in the breast milk or not. This is where the secretor or non-secretor status of the mother is important. And it's also important whether she is Lewis phenotype positive or phenotype negative. So based on that, you would have either the mom who is secretor and Lewis phenotype positive, both positives. She could be both negative, or she could be secretor positive but Lewis phenotype negative, or secretor negative and Lewis phenotype positive. So the clinical implications of these four classifications of different types of moms basically means at any given moment, the amount and variety of HMO that the preterm baby will get in the nursery from the mom will be significantly different if we get the milk from the milk bank as such, because in milk bank, basically you would have donor moms who will be of different types in terms of their ability to secrete different HMOs and their quantity as such. So this is what they call in the current literature as the designer type of milk delivery, matching the infant's mother's status in terms of secretory antigen and Lewis phenotype. That should we be matching what the infant needs when you order pasteurized donor human milk from the milk bank. So that's the future of HMO as such. Quick word about the silylated HMOs. These are quite unique. They have an extremely important role in development and maturity of the brain in a newborn as such, right from the fetal life. It is involved in cognition, signal transduction, and development of the neuronal network in the brain of a preterm fetus as such. And obviously, when that preterm fetus becomes a baby in the nursery, you could imagine that even though the amount of silylated HMO is less in the breast milk, they do have an important role to play when it comes to future cognition, intelligence, so on and so forth. And apart from that, obviously, like the other two types of HMOs, they will have effect on the gut bacteria, the maturation and development of the gastrointestinal system, and control of inflammation, which is the basic of HMOs. So this is the official definition of a prebiotic. Simply, it means any substrate that is selectively utilized by the host microorganisms, conferring a health benefit. Obviously, the natural prebiotics are the human milk oligosaccharides in the breast milk, and they will be specifically stimulating the growth of beneficial bacteria such as bifidobacteria and the lactobacilli as such. And of course, any baby who is given HMOs of different type, we expect that the proportion of bifidobacteria and bacteroids will be going higher up, because these two types of bacteria have got the enzymes to be capable of breaking down the complex milk sugars and then transporting them inside the cell and to utilize them for survival, multiplication, so on and so forth. So that's the reason that even if you give a huge amount of HMO to an infant, but if there are no enough bifidobacteria or bacteroids in the gut, then the administered HMO is not expected to have a good effect on the baby as such. And that is the reason you will see when it comes to the meta-analysis of systematic reviews of randomized trials of different types of prebiotics, the subgroup analysis did show that HMOs didn't have much effect in terms of babies who are less than 28 weeks, because most of the time, of course, based on the practices in the NICU, they are not a significant amount of milk, and there's a heavy exposure to antibiotics. So if you don't have enough bifidobacteria and bacteroids as such, then HMOs are not expected to give a magical improvement in the GI function and structure. Let's talk about human milk oligosaccharides in a synthetic way. So basically, if it comes from animal milk or from plant sources, they are the synthetic oligosaccharides. The most common that we use in practice, if you read the literature, the different trials have been conducted using different types of non-human milk HMOs, and they will be the so-called GOS-FOS. GOS is basically galactose oligosaccharide. FOS means fructose oligosaccharides, and then you have a pectin-derived acidic oligosaccharides. So obviously, the industry is very much after supplementing infant formula with these different types of oligosaccharides and hope that the formula would behave reasonably close to mom's breast milk as such. Amongst the three, amongst the GOS, FOS, and the pectin-derived acidic oligosaccharide, people have found out that pectin-derived components have a direct immunomodulatory effect, which are slightly better than GOS-FOS. We'll cover that when we come to the clinical trials. So this is the systematic review from 2019, 18 randomized trial, total sample size 1,322. As I just told you, the different types of prebiotics assessed in these trials are inulin, lactulose, galactose oligosaccharide, fructooligosacharide, and pectin-derived acidic oligosaccharide. And you could see that prebiotics significantly reduce sepsis, all-cause mortality, length of stay in the nursery, and time to full feeds, but they had no significant effect on necrotizing enterocolitis. And why would that be? People now believe that in tinier babies, especially less than 28-week babies, if their gut flora has been knocked out because of heavy exposure to antibiotics, if they haven't had significant amount of milk in the tummy, then prebiotics alone are not expected to result in significant effect in terms of reducing the risk of NEC. This is where the basic science comes into picture, because there are something called as selectins in the gut. These are finger-like projections. So they are protruding out in the lumen of the gut. So whenever there's inflammation in the gut, beginning of, say, necrotizing enterocolitis, these are the selectins which somehow help the platelets to get activated and combine with the neutrophils. And these activated neutrophils slowly adhere to the endothelial cell lining of the gut. And this is how necrotizing enterocolitis starts in the beginning, the early part. So obviously here the immunomodulatory effect of the pre-existing good bacteria, which is bacteria and bifidobacterium, they are quite important. So if there are not enough good number of bacteria like bifidobacteria in a preterm infant's gut, prebiotic alone are not expected to have significant effect, especially in terms of reduced NEC. So what can be done? What people are believing that till date, the clinical trials have involved those 4 different types of synthetic oligosaccharides: GOS-FOS, inulin, lactulose, and pectin-derived acidic oligosaccharide. They are too simple. They are nowhere as complex as naturally existing HMOs in the gut. And that is the reason that clinical trials have not shown so far significant benefits of oligosaccharides, especially in tiny babies less than 28 weeks of gestation. Till date, we don't know if a single HMO specifically, if we choose something out of those 4 or 5, or is it a combination that will be more protective, because no study has assessed that. And here comes the important part, the technical difficulties, that why the research in the field of prebiotics has not proliferated to the same extent like probiotic, because it is very difficult to concentrate or isolate, extract oligosaccharides from donor human milk or even from animal milk as such. The technology to manufacture synthetic oligosaccharides close to breast milk oligosaccharides without losing their bioactivity and safety is very hard. Very, very limited number of manufacturing plants in the world can do this. Long-term effects, we don't know if we alter the balance of HMOs and the gut microbiota. We even don't know that if we give a tailored approach to extremely preterm infant who are at the highest risk of inflammation, sepsis, so on and so forth, we just covered that if a 26 weeks baby is having a mom who is a non-secretor mother, so would this baby be better off giving milk from a secretor mom? So that is the so-called designer approach to oligosaccharide supplementation using the synthetic oligosaccharides. So far, no study has actually been able to do that. And one of the reasons that people mention why they can't do such big trial, simply because big quantities of such highly tuned, perfectly developed oligosaccharide, big quantities are not available that easily. So they end up conducting studies mainly in rats and mice, different models. And in preterm babies, so far, they have not used any of the fancy synthetic, but very close to breast milk oligosaccharide. Which ones are there? Just to recall a few names, if you remember, I told you to remember those two names, 2FL, 2-fucosyl-lactose. So that one is available commercially now, which is absolutely the identical to natural 2FL milk. Then you got something DSLNT, which is disallyl L-nitrotetroase. That particular oligosaccharide is supposed to be the best one currently available in terms of being identical to breast milk DSNLT. That one has shown significant benefit again in a rat model. But to get enough amount to have a definitive large RCT in preterm infant, that's where the industry is struggling. And that is one of the reasons why prebiotic research is well behind probiotic, say, number of RCTs. Secondly, if you conduct a RCT, then again you'll have to stratify in terms of mother's secretory status, because that's going to be a significant confounding factor. And if you want to give it till certain gestation, for example, right from day 1 up to 34-week gestation, imagine the amount of HMO that you would need for a definitive trial. It will be huge, and currently manufacturers cannot develop that much quantity for us. And last but not the least, somehow the industry, maybe for financial reasons, because they invest a lot, is focused more on adding synthetic or other oligosaccharide to the infant formula. And these days, if our focus is on exclusive human breast milk feeding, then obviously formula is a no-no for us. So once again, there's a big gap between what the industry desires and what the clinicians desire at the bedside. So that's the reason that I don't see that the future of prebiotics, especially in neonatology, in terms of reducing the risk of NAC, sepsis, so on and so forth, looks that bright. I think it's many, many years far away from timing. Now let's go to postbiotics. Postbiotics has been a subject of interest for at least 10 to 15 years. There have been 10 to 12 different definitions. So this is the most recent definition by the International Scientific Association of Prebiotics and Probiotics. That's the consensus statement from 2021. Basically what postbiotic means: preparation of inanimate microorganisms and or their components that will give you health benefit. As simple as that. This is the list of things that could be included as postbiotics. Obviously, products of metabolic products of probiotics, which are short chain fatty acid, they are postbiotics. You got microbial cell fractions, the functional proteins, the polysaccharides that the probiotic bacteria secrete, the extracellular polysaccharides, EPS. Then you got the cell lysate, whatever breaks down products of the probiotic bacteria, use them. Cell wall teichoic acid, or from the cell wall, you got peptidoglycans. From that, they develop neuropeptides. And lastly, the surface pila that sit on the probiotic bacteria. So those pila-like structures can be extracted and you could use them as a postbiotic. Because if adherence and colonization of the gut is one of the important mechanisms of probiotics, how does the probiotic bacteria attach to the gut surface? One of the mechanisms is the existence of those hooks on the surface, which are the pili. Lactobacilli, by and large, are supposed to have reasonably good amount of pili type structures compared to bifidobacteria. So these are the 8 or 9 different types of components from the live probiotic bacteria. If you are able to extract them independently, they are your postbiotics. Sometimes in the literature you would read conditioned media, that's the word they use. It means you grow probiotics in a petri dish, and at the end of the day, throw the bacteria out and take only the supernatant of the culture medium. That will be quite rich in the metabolic products of the bacteria and maybe some cell fragments. So probiotic conditioned media is another popular term in terms of postbiotics. So you'll be surprised. There are dozens and dozens of studies showing potential benefits of even probiotic conditioned media. So keep that at the back of your mind. So this is where we come to ghost biotics. The name sounds scary, but it does justify its existence because sometimes the clever scientists can take out the contents from inside the probiotic bacteria, take everything out, leave only the ghost or the shell of the probiotic bacteria behind, because it has got the cell wall and all important components of the cell wall. And that is the reason that Tavernit is a respected scientist in probiotics. So their team defined in the past something called as paraprobiotics, something that is derived from a live strain. And if it is simply a ghost, an empty shell of a dead bacteria, that's the ghost biotic as such. So anything which is non-viable or a simple a crude cell extract from probiotic, if you give it orally and even topically, if it gives you a host of benefit, that's a ghost biotic or a paraprobiotic. So what are the simple methods that you want to create paraprobiotics or ghost biotics or simply postbiotics? So simple methods are inactivation of a live bacteria by different techniques, obviously heat, chemicals like formalin, gamma radiation, ultraviolet rays, and sonification. So these are the different methods to create postbiotic as such, and given its simplicity, heat treatment is the method of choice for most of the manufacturers. So what are the advantages of postbiotics? Obviously, if the risk of live bacteria, which is the probiotic, is translocation followed by probiotic sepsis, development and spread of antibiotic resistance, worsening local inflammation, and obviously we need a proper cold chain to preserve the viability and stability of the compound. So if you have a postbiotics, obviously there's nothing live in that preparation anymore. So there's a reduced risk of probiotic sepsis, no risk of antibiotic resistance. You cannot aggravate any local inflammation to the same extent like a live bacteria. And obviously the cost will go down because you don't need the cold chain. And most important, such product will be of tremendous help in low middle income nations where everything matters a lot. Couple of comments I have put in there, quite recent ones, that how other people have perceived postbiotic as the best solution in the future for fragile population, obviously like the elderly people, people who are on onco treatments, immunocompromised, and obviously premature infant. And most important, Way's team has pointed out that don't forget postbiotics can be used simultaneously with probiotics to improve the efficacy of the latter. So almost everyone support that concept. Important for us to know as clinicians that both lactobacillus and bifidobacterium species are capable of giving beneficial effect in both heat inactivated form. I've just given you some of the studies that document that how heat inactivated different types of lactobacilli and bifidobacterium both were as effective as live strains. This is something important, something interesting for you to know. What are zombie probiotics? This was a good experiment by the scientists of Nestle. This is the Lactobacillus paracasi strain. In fact, when they heat treated that one, it had basically significantly better adhesive property to the gut compared to a live preparation of the same bacteria. And that's why they call it as a zombie bacteria that is neither dead nor alive, but much better action in terms of adhesion to the gut. So keep that at the back of mind that sometimes heat inactivated probiotic strains basically trials of heat-killed or sonicated probiotics for various diseases, either for prevention or treatment. 40 randomized controlled trial, quite a good sample size, nearly 4,000. 14 trials assessing prevention and 26 trials assessing modified probiotic, modified microbes for treatment of various conditions. And this is what they found out that modified microbes basically were not significantly more or less effective compared to a probiotic in 86% of preventive trials and 69% of treatment trials. And in adults with chronic diarrhea and obesity, they found out that modified probiotics were significantly more effective. That's something good to take note of. In terms of acute pediatric diarrhea, there was only evidence for lactobacillus acidophilus, and not much data on the other things. And they just made it a point that we should make note that when it comes to lactobacillus acidophilus benefit, there was significant heterogeneity in those trials, which is understandable because no matter what we call as a probiotic, there'll be always differences in the strains, in the setting, in the dose, in the duration, so on and so forth. Important to know that adverse events basically were not that common, and they were comparable in modified microbiomes compared to live probiotics and other controls. So this is what we decided that we could think of in terms of paraprobiotics as the next frontier for preterm infant a couple of years ago. I'll just take you through what we recently completed. This was a pilot randomized controlled trial, which my colleague Gayatri looked after as her topic of research. So we compared a probiotic with a heat inactivated preparation of the same probiotic strains as such. And our hypothesis was it will be safe, tolerated, and will have comparable anti-inflammatory effect on the gut as assessed by fecal calprotectin levels. So we recruited babies less than 32 weeks of gestation who were just about ready to start on feeds or on feed for not more than 12 hours, got the consent. Anyone who had significant congenital malformations, chromosomal aberration, and importantly, not ready for feeds or has been on feeds for more than 12 hours were excluded. This was the intervention, just for your information, that we use a preparation which had 3 bifidobacteria. M16V is the strain that we have been using routinely for many years now. Added to that this time was the Bifidobacterium longum, subspecies infantis, M63, and the other one, Bifidobacterium longum, BB536. And the control arm was the live mixture of these 3 identical strains. So this is the basis of the trial, live versus heat inactivated mixture from 3 strains as such. And how did we inactivate the preparation to have the intervention ready? Expose the culture time to 90 degrees for about 15 minutes. Very simple to do. Sorry, just one sec. Something just went there. Okay. Yeah, so this was the comparison, live versus inactivated. I think I just pressed something, went wrong. Okay, back. Primary outcome was safety in terms of blood culture positive sepsis because of the administered probiotic strains, adverse effects such as abdominal distension, vomiting, and diarrhea. Primary outcome was basically fecal calprotectin level, and we estimated the sample size adequate to detect significant change in fecal calprotectin levels. Totally, I think we recruited about 90 or 92 infants, and the findings will be probably ready in the next few months, so watch the space. So this is where we take a break and think, if we are not interested in prebiotics because there's not much information available, or what we want is not available in a reasonable quantity for a clinical trial or clinical use, we don't want postbiotics because we're still scared about them, right? For the right reason that not much data in neonatology. And we don't want to use anything like probiotic. So what do we do? So basically the advice, this comes from US, just be nice and slow, and how slow you can be. So what they did here, they had a very slow standardized feeding regimen for extremely low birth weight infant, less than a kilo. The published results, as you see in this slide, are based on babies who are less than this is comparison of 2 cohorts, historical cohort where there was no standardized slow feeding protocol, and a cohort where they were so slow in a standardized way to feed the babies. And you could see what was the protocol. No feeding for 10 to 14 days, and then increase the milk by less than 10 milk per kilo per day. Not a surprise that it will take at least a month to be on 150 mils per kilo per day. But interestingly, let's see, why did they do that? Because they had no milk bank on site. Their incidence of NEC was sky high. Dependence on TPN was too much. So they were actually fed up. If you read that paper, they said, we had no choice left but to do something drastic. So based on whatever early publications on benefits of standardized feeding protocol, they decided to standardize the whole thing and take it nice and slow. And what did they achieve? This is what they achieved. That the breast milk initiation rate was higher. Most importantly, NEC went down from 16.2%. Mind you, we are talking about babies less than 750 grams. So it went down from 16% or so down to 1%. Surgical NEC went down to 0%. Composite outcome NEC or death went down from nearly 30% down to 7.5%. Similar rate of late onset sepsis. And as a bonus, they had high discharge weight, lower incidence of extrauterine growth retardation, and similar length of stay. So this brings to a question that if you are desperate and you don't want any biotic in your nursery, what can be done apart from obviously good use of antenatal steroid, reasonably standardized approach to feeding, early preference for feeding with breast milk. And this is where the so-called slow increment come into picture, how slow you can be. So most of the time people will say, hey guys, if you're taking a month to go on full feed, this is not good. But on the other hand, think, what is the health burden of NEC, especially in this population? So if you're that desperate, this was the solution coming from one of the nurseries in the US. So keep that at the back of your mind about how slow you can be. And obviously, because they took a longer time to go on full feed, obviously, the duration of parental nutrition was high, the need for central venous lines for longer, higher incidence of cholestasis, and increased serum alkaline phosphatase. So that's the price they were willing to pay, but to get the incidence of NEC and the outcomes of NEC under control. So I will quickly now cover, because we can't finish this talk without probiotics. So these are the top 10 controversies. These are the 5 in the first line. Till date, people say effect of probiotics are strain specific, so don't trust any meta-analysis. People from UK, the ghost of the PIPS trial is still haunting them. Some people from the US keep on telling that there's not enough data on babies less than a kilo or less than 28 weeks. Some people worry that probiotic products can be contaminated based on that one case report, so we don't want to use it. Some people will say, we want to use it, but we don't have good product, safe product. Then there are some more controversy that, yeah, if you're feeding the babies with breast milk, we don't need probiotics. If our baseline risk of NAC is very low, we don't need probiotics. Some people say we don't know the long-term safety of probiotics. And I was quite surprised. Even till date, some people say we don't know exactly how probiotic works. And this is despite the fact that there are at least 26 known different mechanisms of benefits of probiotics. There was a hilarious call for, we need a confirmatory trial of probiotics in extremely low birth rate infants from North America, from North USA now. So nothing happened after that call, and till date, that trial has not taken place in North America, or for that matter, anywhere in the world, because the sample size of such a trial would be at least 4,000 to 6,000 babies less than 28 weeks. So these 10 controversies, I don't have much time to talk on them as such, but I can tell you that none of these objections are valid anymore. First one, when they say that probiotic effects are strain specific, so you can't combine the data from different strains together. This is no longer true. And why? Because of this new paper that came from the group of probiotic scientists. They said that if the probiotic bacteria that you are using belong to the common genus like Bifidobacterium or Lactobacillus, they do share many mechanisms of benefits in terms of reduced risk of NEC, inflammation, sepsis, so on and so forth together. For example, the important property of a probiotic bacteria is to secrete short-chain fatty acids. Then you got the cell wall component which is called the cell wall teichoic acid. Then you got mucus binding proteins. You have fibronectin binding protein. You got surface layer associated proteins, the pili protein, the ability to synthesize vitamins. All these properties are equally shared as long as the strains belong to the genus Bifidobacterium and Lactobacillus. And that means way back in 2013, when the basic scientists from US had pointed out that the fact that despite using different types of probiotics, we have consistently seen benefit, it means there must be something common to all of them. And now we know, yes, they share many, many beneficial pathways together. So that's the reason, as long as they are Lactobacillus and Bifidobacterium, it is absolutely valid to pull the data together. And the last thing that I would point out, that today the data is available on extremely low birth weight infant, at least 5,000 of them. If you check our most recent papers, we have provided data on those many ELBW infant in terms of routine use and their benefits. From randomized controlled trial, there are at least 2,000 babies who are under 28 or under 1 kilo. So there's enough data on ELBW infant now to say that yes, we should be using probiotics even for babies less than a kilo. So that comes to the end of the discussion and the presentation today. Before, I'm happy to take any question. So what's the option for those who do not believe in any biotics? If it comes to not doing anything, that's fine, as long as you have shared what your concerns are with the parents in an open and transparent manner. But if you're worried about probiotics, what are the options? So these are the two simple options given in the current commentary in JAMA Pediatrics quite recently. Either as a purist, you could wait for a randomized controlled trial recruiting 80,000 babies to just confirm that probiotics don't work. Or as a common sense based on the current available incidence, you say, yes, I'm happy to accept the current uncertainty because I know that the benefits outweigh the risk and I will be starting to use probiotics from tomorrow. So that's where I think we'll take a break and I'll be happy to answer your questions. Thank you for your time.
Wonderful. Wonderful, Sanjay. Before we go on to question time, I'll ask one of our very good friends actually to unmask herself. Elma. Do you remember Elma Enriquez?
Absolutely, my dear friend.
We found her.
Yes, good to see you. Good to know she's there. Hello,
So these are my two favorite people in the whole world, Elma and Sanjay, the dynamic duo from the Royal in Paddington. How are you, Elma?
We started.
I'm good.
Hi, Elma.
Hi.
Good to
Can
see
you hear me?
Yes, of course. Of course. So good to see
You're
you.
still brilliant as ever.
He looks so distinguished now, doesn't he, Elma? And so do you. You look fantastic. Thank you for joining.
Thank you too.
Okay, that was a marvelous talk. Do you have any questions? We'll give you first opportunity to ask questions, Elma. Have you got any questions for Sanjay?
While we wait for the questions, I've just left the slide to show our incidence of NEC in King Edward Nursery, a 15-year journey. So you could see that for the last, since 2015 or 16, our incidence of definite NEC in babies less than 28 weeks is quite low, hardly near 1.8 or 2%.
Okay, and also notice on the audience, if Elma, have you got any questions for Sanjay?
No, later. Okay.
Later, you store them up. Okay, fantastic. Okay, I asked one of our gastroenterologists to be on the panel, to be online, and I see that Dr. Keith Uy, my twin, is online. Keith, do you have any comments on Sanjay's talk?
Oh, hi, Julie. Thanks for putting me on the spot. I was actually cycling part of the talk, during part of the talk, so I couldn't listen to everything. But well done on all the work's done. I actually do have a comment, and I apologize because I was, as I said, I was cycling when you were talking as well, so I couldn't listen.
Gotta keep healthy, man. Gotta keep healthy.
While watching for the cars. One of the comments would be the use of calprotectin in your study that you mentioned just towards the end. So I think one of the issues with fecal calprotectin is it's actually not great as a marker in very young because there's a physiologically high levels of calprotectin, which can make it very difficult to distinguish between pathologic states of inflammation and normal physiologic elevations. So that was, I guess that was one of the comments that I would like to say, but I wasn't sure what the experience would be. Yeah.
No, that's right. But in the randomized controlled trials, focusing on babies less than 32 weeks, if you do see a significant difference between the two arms, all we want is, are both live and inactivated strains having comparable anti-inflammatory effects on the gut? That's the aim. We know that there's a physiological variation between what's normal and what's evolving in a preterm baby, but the idea is to compare the two in a proper randomized controlled trial. So whatever you would see will be reliable, especially when it is powered to see one standard or two standard deviation difference between the two. It's not the question of high.
Sure, except well, I guess what I'm saying is it's actually not a measure, it's not a good measure of inflammation in the young. That's yeah.
And that's the closest we can get to inflammatory markers in a gut in a preterm baby. There are not many other markers. Very difficult.
Yes, you're right. I mean, that's the most common. So there are other markers like MTPK, S100A12. So there's a few other markers that are less commonly used, but that does not have that swing.
And we don't have any data on those markers in preterm babies yet. Lost your voice, Julie.
Julie, we can't hear you, Julie.
Bummer, I'm muted. So sorry, that's the zoomed out. What are your thoughts about using probiotics, prebiotics, postbiotics, whatever, on the older kids, the 32 to 36 weekers, or even the term infants, which is what is happening in the community?
So far, there's hardly any data to show that beyond 34 weeks, that's where usually the neonatologist will stop, because after 34 weeks, the risk of NEC and late onset sepsis is very minimal, at least in the typical Western world setup. So in absence of data, the only time I could think that you may be using probiotics, especially to reduce the risk of NEC beyond 34 weeks, will be cases where you're dealing with significant intrauterine growth restriction, small for gestational age babies, or not much donor milk available. So those are the cases where you could make an exception, but there are no studies to show that probiotic supplementation is beneficial for babies who are late preterm, near term, or term as such. Not many studies have been conducted in that area.
What about other issues besides NEC then? Long-term health?
Yeah, that's a good point, because people keep on discussing only about NEC. People forget that probiotics have effect on late onset sepsis, feeding intolerance, all-cause mortality, and possibly long-term benefits in terms of neurodevelopment, growth, and cognition as such. So those areas basically should never be forgotten when you're discussing about benefits of probiotics. For a neonatologist, late onset sepsis, feeding intolerance, and all-cause mortality, there could be issues in the nursery. So based on what are the problems in the nursery, you could be justifying the use of probiotics in an NICU. Beyond NICU, the areas open for research to check is basically long-term effects of probiotics on neurodevelopment and growth. Currently,
and how many patients will you need for that one?
Depends on how much basically improvement you are trying to expect, correct? Because we have no baseline data to say, because currently out of 63 randomized controlled trials, the meta-analysis has got only 7 assessing long-term development, and it showed probiotics had no significant effect in terms of long-term neurodevelopment and growth, the risk of cerebral palsy and cognition, so on and so forth. So at least for the time being, we could say that, yeah, they are safe in the long run. But if they have benefits, then it needs to be tested properly.
Yeah. Mm-hmm.
Least you could do, least one could do will be if you are using probiotics routinely in a tightly controlled fashion. The only way is cohort studies comparing past outcomes with the current ones in terms of Bailey assessment, 3-year assessment, so on and so forth, the proper population-based data.
Yeah. Okay, John's got a question. Says, Sanjay, thanks for a great talk. Can you explain the reduction in NEC at KMH over the last 5 years?
Basically, what we have seen, KM always had milk bank on site from 2006. Antenatal steroids all over Australia and New Zealand, we are quite lucky that the exposure is at least 89 to 92%. We have standardized feeding protocol in place since 2003. And from 2010 onwards, we have introduced probiotics routine use as such. And later on, while providing routine supplement of probiotics, we have been conducting research as well in terms of randomized controlled trial of, say, single versus triple strain bacteria. That's another trial my colleague, Dr. Gayatri, had just finished. The paper hopefully will be coming out quite soon. Then we went on to conduct the randomized controlled trial of heat inactivated versus the proper probiotic as such. And we promised ourselves in 2011, you will see that we quoted that in our paper on evidence-based guidelines, that there's no reason why research cannot be conducted when you're offering routine probiotic supplementation to babies in the nursery. So that's what we did. And I believe that the increased awareness about the disease in the nursery as well is an important issue, that how overall everything is working together, at least in King Edward Nursery, that we have been quite lucky to see a significant drop. So it's not just one thing in isolation as such, everything together. Antenatal steroids, standardized feeding protocol, preferential early feeding with mother's breast milk or donor human milk, keep the formula out, give probiotic supplementation, and be on guard to be having so-called NEC zero tolerance type of attitude.
John, is that you happy? He doesn't know how to unmute himself. Happy? You happy?
Thanks, Sanjay.
Thank you.
Good stuff. Could I ask Dr. Kutsuda, he's online now from Japan, to speak about his views on your talk. Dr. Kutsuda?
Hi, this is Satoshi Kutsuda from Tokyo, Japan. I believe I exchanged several emails with Dr. Patole before about our randomized control trial about probiotics. Thank you for very interesting lecture today. Actually, almost all Japanese NICU using probiotics. So it's very difficult to see the benefit of probiotics use in Japan, but all neonatologists believe it actually works. So I totally agree. We should keep using the probiotics for very preterm infant. However, prebiotics and postbiotics, it's not popular yet in Japan. So actually, did you already start to supplement pre or post probiotics in your practice?
Sorry, I didn't get you,
Doctor. You already use probiotics daily, right?
Mm-hmm. Yes.
But how about pre or post biotics? Are you using routinely these materials?
Sure. Our plan is basically once our study is published in a peer-reviewed form, then we'll have a joint discussion in the entire team, and then we'll decide what's our next step going to be. Is it going to be comparison of single versus changing from single to multi-strain product, or comparing live 3 strains with inactivated 3 strains as such, and select a proper clinically important outcome. What we finished is just basically pilot studies. So what could be the clinical outcomes is an important issue for us, because our rates of NEC, just like most of the Western world, are quite low. So to have NEC as the primary outcome is quite difficult. Chronic lung disease is a completely different beast as such. Late onset sepsis, basically probiotics work through the gut. We have covered that in our old publication from 2010, that why the effect size of probiotics for late onset sepsis is not as impressive as it is for NEC. And that's because probiotics will act mainly through the gut. It will not have much benefit in terms of the sepsis that comes from lines, tubes, and catheters. And that's the reason that we will, as a team, have to decide our direction for further research and clinical use of probiotics, whether change to multi-strain probiotic or compare inactivated with live probiotics on a bigger scale. We could go for a multi-center trial or a cluster randomized control trial. That remains to be discussed in our team after our papers get published.
Okay, thank you. Maybe right now you can hear my voice much clearer because I select wrong mic. So thank you for your information. So we are waiting your result of randomized control trial.
Yes, yes. Few more, just 2 or 3 months to go, hopefully.
Oh, very close.
So, and then you would need friends for your mega trial, right?
Yes. Yeah. Because everyone has learned from the different meta-analysis that maybe multi-strain product is better than single strain. But then the question is, how many strains make it a multi-strain? 2, 3, 4, 5. So there are lots of issues to be discussed when it comes to even comparing single versus multi-strain. Easiest will be comparing live, whichever product people are using, against the heat inactivated form, because eliminating the risk of antibiotic resistance, probiotic sepsis is the priority. If reducing the cost is important for low income countries, if improving the shelf life is good for us as well, then in all those accounts, as you saw in the various slides, that inactivated probiotic is probably the way of future, because they can be given even to the critically ill infants, or say extremely growth restricted tiny babies where even 1 ml of milk gives you significantly bloated tummy, you get scared and you stop the milk, or post-operative babies. So there's a lot of scope for postbiotics.
Yeah, great.
Thank you, Dr. Kusuda. I don't know the cost, Sanjay. What is the cost difference?
Nothing, zero, because you just expose the culture tank to 80 degrees for 15 minutes and it's done.
But if you buy it from like Chemist Warehouse or something?
So far, commercially, no heat inactivated product is easily available, especially which will be suitable for preterm infant, because the fact is ours will probably only the second proper study in the literature, where you know everything about the strain that have been used to develop the heat inactivated form. Yeah.
Ooh, scaling up will be a bit of a challenge.
Probably not, because if the product that you are going to suggest to be used in a heat inactivated form, if it is available easily as a live probiotic, then that should not be a major issue. Yeah. If you're not talking about, say, lactobacillus royalty type of product, which is oil-based, which is a complicated way to manufacture, quite expensive, then the logistics and supply for big trials is a practical issue. But for a simple bifidobacterium type of product, if you can just expose it to heat and make a heat inactivated product as well, cost is not an issue. Logistics are not a problem at all.
Right. And I'm sorry, I don't know anything about this, about the shelf life. What would the expected shelf life be?
If it is the heat inactivated product, then shelf life is not a problem at all. Not a problem at all. Because they are already dead. And even when dead, they are still beneficial.
Very exciting. Ghosts and zombies. I learned something today.
Absolutely. You stay in come to WA, you'll get many things.
WA needs help, yes.
2 years cut off from the world, you will be a zombie.
We hope to get you out of WA soon, Sanjay. Well,
neither live, not dead, but still helpful.
Zombies go forever. Yes. All right. So we're very quiet on the chat today. Everyone's quite quite amused by the zombies and the ghosts.
Yes.
Are there any other questions for Sanjay? Everyone's stunned, Sanjay. So one of the other questions I asked you and you never answered me is that, you know, people moms especially are very, very attracted by the probiotics, prebiotics, whatever biotic, right? And they go on forever, 2, 4 months, 5 months. You know, what is the message in the community there?
I think they're just using the way we have been consuming probiotics in different forms for centuries, that they are something good for general health and well-being. But as a scientific person, there's hardly any data to say that, yes, you could discharge home all babies to be continued on probiotics for a certain number of years or months. So basically, that's where there's another research that needs to be done. Stop versus continue probiotics after discharge home of preterm infant. How long? 3 months, 6 months, till the vaccinations are done? That's the whole new field of research open.
Totally agree. Is there any cost analysis done on this treatment?
Basically, I think one of the systematic reviews, the title itself says that yes, probiotics are cost beneficial. Yeah, because 80 to 90 cents a day compared to 60 days of extra stay in the nursery because of surgical NEC, or 22 days of extra stay in the nursery because of medically managed NEC. The cost is not an issue at all. 1 day stay, if you reduce in the nursery, we have saved at least $1,000. And 90 days treatment for a 23-weeker infant with probiotics up to 34 or 36 weeks of gestation would still be less than $100. So 100 versus 1,000, no match. So
no match.
No wonder the systematic review showed that yes, they are cost effective. Unless, let me remind that unless you go for a product like Lactobacillus reuteri, which is quite expensive, quite expensive.
And you use it, of course, is your thing. Who uses that?
Don't know. I honestly don't know. It is supposed to be good for colic, so I'll leave it to the pediatricians. Colic is a transient thing, and the total data supporting benefits of Lactobacillus reuteri for colic is 200 babies in each arm coming from 7 different trials. So that's the irony of evidence-based medicine, that in probiotics for preterm infants, so far there have been 63 randomized controlled trials, 31 studies reporting benefits in routine use as such. Total sample size is 86,000 total as of this date, and people are still discussing the pros and cons of probiotic. And on the other hand, they are recommending probiotic for infant colic based on a data on only less than 500 babies. A condition which is transient, which is benign, which is not going to kill anyone. So that's the irony of evidence-based medicine.
But it's a good sales.
Yes.
Yeah, that's right. When the desperate moms, yes, that's right. And I do echo what Javid has said. Thank you, Sanjay. As usual, you're a wealth of information and providing that in a very short time.
Thank you so much.
Yes, thank you. That was a very, very good lecture. Thank you. Very enlightening. So if there are no more questions, we might come to a halt now. Thank you again, Sanjay, for giving us such a lot of info in a very, less than an hour. That's amazing. If anyone's interested in RCT, please contact Dr. Patole. He doesn't have a mobile phone, so you'll have to email him.
That's right.
Is that right? No mobile phone. The only neonatologist without a mobile phone.
Yes, and I can still survive.
He is doing well. So that's our last lecture for the year, everyone. Thank you for all your support in the last 2 years during these crazy, crazy times. We may or may not come back next year, depending on how our borders are. But in the meantime, stay safe and hope to see you again in person very soon. All right.
Thank you,
Thank
Julie.
you. Thank you, Sanjay. All right. Bye, everyone.
Thank you.
Bye-bye.
Bye-bye.